Hello and welcome to this video. So today we're going to be teaching you how to perform a risk of bias assessment for a randomized controlled trial. Now the first step is to get the tool which we'll use. And to do that, simply type risk of bias 2 tool into the Google search bar and you'll see a couple of links popping up. Now click on the first one and that should lead you to Cochrane's website. And in this website you'll just click on this link here and click on current version, and that should lead you to a window with 4 hotlinks. Now, the one we'll be using here is the Excel tool to implement the risk of bias 2 tool. I've already downloaded it. But you'll find that these other documents, particularly the full guidance document and the crib sheet summarizing the tool documents, are pretty useful to aid you in using the tool. They contain a bit more detail than what we'll be delving into today, and so you might want to take a look at them. So once you've downloaded the tool, this is how it would look once you open up the Excel sheet that you'll download, and you'll click on the first box here, and it should open up a window that looks pretty complicated and overwhelming, but hopefully it won't look as overwhelming by the time you're done. So you might notice that the window contains a lot of options and a lot of details, not all of which are necessary for our purposes. So in this video we'll mostly be discussing the main or key aspects related to the assessment rather than delving into every detail. Now the first step is to enter the name of the trial which you'll be assessing. In our case, we're going to be assessing a trial called the PARADIGM-HF trial, so that's what we'll enter in here. And it's generally a good idea to also type in the name of the outcome which you're assessing the risk of bias for. So in our case, we'll be interested in all-cause mortality, so that's what we're going to type in here. The rest of these boxes are, they're nice to fill in, but they're not necessary for the tool to work, so we'll just be bypassing them for now, and we'll focus on the important stuff. So the second box we'll be clicking is this one right here, and we're going to choose intention to treat in this box right here, and we'll be delving into more detail about what exactly this means, but in one of the risk of bias domains. But for now, let's just pick this one, and a couple of minutes down the road you're going to know why it is that we are picking this one. So now that we've written in our assessment ID as well as chosen the intention to treat effect, we're ready to start our assessment of bias. Now you'll notice that each of these domains here, they're 1 through 5, each of them consists of several what are called signaling questions. Now, signaling questions are essentially, these are the components of each process. So with respect to randomization, we're going to be asking 3 questions, and these 3 questions considered together will allow us to pass an overall judgment on this domain. Likewise with all the other domains, right? So each of these domains, there's one big domain called randomization, another big domain called selection of the reported result, another domain called measurement of the outcome, and so on and so forth. And each of them consist of subdomains or signaling questions, the sum of which will allow us to pass an overall judgment on each domain. And we're going to go through a practical example here, and the trial we're going to be using for our example is the PARADIGM-HF trial. Now this trial is available over the New England Journal of Medicine. The trial as well as the related supplementary material, the protocol, all of that stuff is available over there, so it should be relatively easy to download. And so let's start with the first domain. So when we go over to our tool here, we'll see that the first domain is the randomization process domain, and it has 3 signaling questions or subdomains, so to speak. Now, the first question asked us, was the allocation sequence random? Now, in order for an allocation sequence to be random, it has to be something that is truly random, that is not something you could predict ahead of time. And examples of this would be something like a computer-generated list, for instance, or a coin toss, or rolling the dice, or something along these lines. These are things which you can't really predict ahead of time. Now, there are bad ways of randomizing as well, and these would include things like, for instance, enrolling patients depending on the day of the week that they come in, right? Because the day of the week that they come into the clinic it's not really random. They might be coming in on a certain day because a certain doctor is there that day, or because a certain service is open that day. So it's very important that we make sure that the randomization pattern which was generated was actually generated based on something that's truly random, not something that's pseudo random, so to speak. Now, if we go over to our trial, in the methods section, we'll notice that most trials generally include a description of how they randomize patients. So in this trial, I've highlighted the relevant parts in red, and it says that patients were randomly assigned in a 1-to-1 ratio to double-blind treatment with either enalapril at a dose of 10 milligrams daily, or the neprilysin inhibitor is called LCZ696. But we're just going to call it neprilysin, or sacubitril valsartan, right? So at a dose of 200 milligrams twice daily, with the use of a computer-generated randomization system. So this is something that we can be relatively assured is random. It's not something that the investigators could predict ahead of time. So randomization, a computer randomization system is okay, a coin toss is okay, a dice roll is okay, but basing it on the date of admission, for instance, is not okay. Now I'll go over back to my sheet, and in the question, was the allocation sequence random? I'm gonna type in a Y. That's a yes, right? Now the second question asks us, was the allocation sequence concealed until the participants were enrolled and assigned to their interventions? Now what does this mean? So let's say I randomize the first patient to enalapril and the second patient to sacubitril valsartan, right? Now, is the doctor who's enrolling patients going to know ahead of time that the next patient is going to get enalapril and the patient after him is going to get sacubitril valsartan? If he knows this, then it's very easy to subvert the randomization process. It's very easy to simply assign the sicker patients to enalapril and the well patients to sacubitril valsartan and get really impressive results for sacubitril valsartan, even though the treatments might be equal in efficacy. Now, we know they're not, but in a hypothetical scenario, it would be very easy to subvert the randomization process this way. And so what we do is we make sure that the enrolling physician does not know the sequence of the randomization process. That is to say, he does not know whether the next patient is going to get assigned to sacubitril or whether he's going to get assigned to enalapril. So not only do you generate the randomization sequence in random pattern, in this example using a computer, but you make sure that this randomization pattern which you've just generated is not known to the investigators, is concealed from the investigators. Hence why the question is asking us, was the allocation sequence concealed, right? So it's concealed from the investigators up until the point at which the patients are enrolled, right? Now, how do we ensure that this is the case? Well, there are two main methods to do this. One is called central allocation. So that's basically when you're an investigator at a center, a patient comes in, he fulfills the inclusion criteria, he wants to be enrolled in the trial. You'll call up a coordination center or a central allocation system, which will tell you this patient is going to take the drug container number whatever, You're not going to be able to tell ahead of time which drug container the patient is going to get. You're only going to know which drug container the patient is going to get after you call up the randomization center or the allocation center, right? That's what's known as central allocation. So there's basically a central entity that's responsible for telling physicians or investigators, once they've enrolled patients, which drug container the patient is going to get, right? That's one method. Another commonly used method is using envelopes, but not just simple transparent envelopes, because you can imagine if you have an envelope in your hand and it's transparent or translucent, you could easily put it up against the sunlight and take a look at what's inside. And in a scenario like that, even if the randomization process was properly done, you'd still be able to tell ahead of time which patients were going to get which treatments through the translucent envelopes. And so what we usually do is we use opaque sealed envelopes, ones that are tamper-proof that the investigator cannot open ahead of time without it showing, and ones that are opaque so that the investigator cannot simply see what's inside. Right? So one of these two methods is acceptable. Central allocation, you pull up a central system, or opaque sealed envelopes. Right? Now, let's take a look at what they did in our trial. Now we can see here that they say, right after the randomization bit, they say that it involved concealed study group assignments. Now, this is usually a bit too vague for our comfort. Concealed study group assignments does imply that the randomization sequence was concealed, that the investigators did not know it ahead of time. But let's say I want to take a look at a bit more detail. Let's say I'm not comfortable with this wording enough, and I want to take a look at what they really did. So I'm just going to get the protocol from the New England Journal of Medicine website. And I've already downloaded it, and you can download it from there if you want to follow along. And yeah, in section number 6, this one right here, the treatment. They should have a section on how they randomize or how they assign patients to their treatment arms. And this is the relevant bit right here. At visit number 5, and patients are randomized to one of the two treatments at visit number 5, not visit number 1. The investigator or the delegate will call the interactive voice response system, that's IVRS, enter the patient's number, and confirm that the patient qualifies for randomization. And then the IVRS will assign a randomization number, which will be used to give them a certain treatment. And yeah, so basically what the investigator is doing here is he's calling up a central system, and the central system is telling him, give patient X this drug or that drug, right? So in this case, it's clearly a case of central allocation. The investigator has absolutely no control or no way to predict which drug each patient will be receiving, right? They're simply calling up a system, and the system is telling them what to do. So this is a pretty clear-cut example of a central allocation scheme. So now I'm going to go over to my Excel sheet, and I'm going to type in yes in response to 1.2, which concerns the allocation sequence concealment. Now, question 1.3 asks us, did the baseline differences between the intervention groups suggest a problem with the randomization process? Now, what this question is trying to get at is that if the randomization process was completely appended by the investigators, if it was completely, subverted by the investigators, there might be some evidence of that in Table 1. Table 1 is ordinarily where the investigators display the baseline characteristics of the two patients. So if the baseline characteristics are very different, that might be a hint that something went wrong with the randomization, right? So in our example, if we go over to Table 1, you can scroll through this table if you download the PDF from the New England Journal of Medicine, and you'll see that most of the characteristics are pretty closely matched between the two cohorts, right? Most of the differences are very, very minimal. Now, one thing I should add is that some differences are expected. Randomization doesn't mean that the baseline characteristics will be exactly identical, and you could even get, in some trials, they add a third column here with a p-value, and, one of these p-values can actually be significant, suggesting that there's a statistically significant difference between the baseline characteristics of the two groups. Now, that's not necessarily a hint that the randomization was appended or subverted by the investigators, because it's completely expected, if the randomization process was perfectly done. It's completely expected that, about 1 in 20 of your baseline variables are going to differ at a statistically significant level between the two groups. So, if you have a table like this with like 30, 40 variables, you might expect to see one or two statistically significant differences. That's perfectly expected, right? However, if you see a consistent pattern where you see more differences than you would expect by mere chance, and most of these differences seem to be stacked up against one group, that might be a stronger hint that something's off, right? Now, especially if these variables are, things which we know a priori to be important prognostic variables. So things like the severity of their heart failure class, for instance, or other important comorbidities. Now, another hint that something might be wrong is if table 1 omits some key variables. So if you know through your expertise that there are like 2 or 3 important key prognostic variables, and you find none of them in table 1, that might be a hint that the investigators are maybe trying to hide these key variables. So that's another important point. Now, in this case, most of the prognostically important variables for heart failure are here, and the differences are pretty slim, right? So I'm going to go over to my Excel sheet, and I'm going to type in no, the baseline differences did not suggest a problem. Now, once you're done with all the subdomains or the signaling questions for a specific domain, you can click on the algorithm box right here, which will type in the automated algorithmic reply, which is a low risk of bias assessment for this particular domain, for the randomization domain. And there's also room for your own subjective judgment. Now, although the algorithmic result might seem a bit more objective, it's generally a good idea to weigh up your own judgment of the result, and weigh it up more heavily than the algorithm's result. The reason being is that the algorithm does not know how to weigh up different aspects against each other. If there is a slight problem with one domain, the algorithm might take that to mean that this domain is completely subverted. Even though you, as the assessor, know that it's only really a very slight problem that does not warrant a high risk of bias judgment. And the opposite is true. So generally speaking, it's a good idea to use your own judgment, and value it over and above that of the algorithm. Right? The algorithm is just there as a supporting tool, but it's not really it shouldn't really have the final say. Now, if I go over to the next domain, it's called deviations from intended interventions, which sounds like a mouthful and sounds a bit intimidating, but let's try and go through the signaling questions or the subdomains and try to explain what this domain is trying to get at. So the first question asks us, were the participants aware of their assigned intervention during the trial? And the second question is a related one, where the carers and the people delivering the intervention, so the doctors, the nurses, the practitioners around the patient, aware of the participants' assigned intervention. So this is basically concerned with blinding, right? Were the patients and the doctors blinded, or were they not? Was it an open label trial? So if you go over to the trial, in the methods section, you'll see that they say the participants were randomly assigned in a 1-to-1 ratio to double-blind treatment. Now, ordinarily, the word double-blind treatment is not sufficient to say that the trial was definitely blinded, because the blinding might be subverted, or it might not have been carried out properly. And so if you want to take a deeper look at how the blinding was done, it's generally a good idea to go over to the protocol, and under treatment section number 6, there should be a section dedicated to the blinding process, so 6.4, right? Now, you'll see a pretty lengthy description of how they went about blinding the patients and the doctors, and essentially involves the things that you'd expect. Identical packaging, labeling, administration methods, appearances, smells. The two drug containers are basically mirror images of one another. And that gives you plenty assurance that it truly was blinded. And so we're going to go over to our Excel sheet right here, and we're going to type in no here and no here. Now, you'll notice that this wiped out a couple of the questions, and that's because some of these questions are only really relevant if you've answered yes to one of these preceding questions, right? Now, these questions are therefore not relevant for this particular trial, but let's go over them because there will be many cases. In fact, in most cases, that you won't have double blinding. In many cases, you'll have at least either the doctors or the patients being aware of their treatments. So, what these sections aim to get at? Well, let's take a look at the first one. Were there deviations from the intended interventions because of the trial context? Now, let's strike an example of this. Right? What does deviations from intended interventions mean? What it's trying to get at is additional interventions, for instance, aside from those intended by the trial protocol. So what could be an example of this? Well, let's say that you're trying to compare antidepressants, that's one class of medications, versus placebo for the treatment of people with major depressive disorder, right? Now, let's say that the trial is not blinded and that the patients know which arm that they've been assigned to, whether they've been assigned to the active antidepressant arm or the placebo arm. Now, one thing you can imagine happening is that the patients assigned to the placebo arm might seek alternative treatment. So they might, for instance, schedule CBT sessions, right? And cognitive behavioral therapy, we know, is something that can improve depression outcomes. So in a scenario like that, you'd answer the question, were there deviations from the intended intervention? You'd type that in as yes if you had reason to suspect that the patients really did seek CBT, the patients assigned to placebo. And the next question, were these deviations likely to have affected the outcome? You type in yes as well because of your domain knowledge. You know that CBT in that scenario would indeed affect the outcome, would indeed help the people with depression, and therefore instead of the comparison being antidepressants versus placebo, it's effectively going to end up being antidepressants versus CBT, because all of the people assigned to the placebo arm went to seek CBT, right? So that's an example where you could plausibly see deviations from the intended intervention and where these deviations really could have an important impact on the outcome. Now, the next question is asking us whether these deviations were balanced between the two groups. So in our previous example, if you assume that, let's say, 90% of the patients assigned to placebo went to CBT, but only 10% of the patients in the antidepressant arm went to CBT, that's a pretty gross example where it would show that the deviations were not balanced between the two groups. The deviations were, pretty different, right? Only 10% versus 90%. Now, an example of the opposite would be if, say, 50% in both arms went to seek CBT, right? And that would be an example where the deviations would be balanced between the two groups. Now, there are other examples you could find of this in the handbook, in the manual that I showed you earlier in this video. It goes through, I think, 3 examples that should give you a more concrete idea of what these domains refer to. For the purposes of our trial, that's not really very relevant because both of the treatment arms were blinded, right? But you can imagine if you're conducting an open label trial or a trial of, say, surgery versus versus conservative treatment, blinding would not be possible, and so these domains would become critical in that scenario. Now, one thing I should add is that even if you do the blinding properly, that is, even if you give the participants one of 2 identical drugs, with identical shapes and smells and whatnot, there are situations where the blinding can be subverted nevertheless. And these would include situations where the drug has a very characteristic side effect. So let's say that the drug causes, urine discoloration or some form of skin discoloration or a rash or something else like that. That's a side effect which would be easily apparent to the patient or the doctor, and which the patient or the doctor would be able to tell the two drugs apart. So if I, take a drug and my urine turns to a weird color, or if I get a weird skin rash, it's generally a safe bet that I'm taking the active drug with that specific side effect rather than the placebo, right? So these are situations in which you'll be doing everything right with respect to the blinding, but where the patients will still be able to tell apart the two interventions because of that characteristic side effect. The patients or the doctors, I should say, unless and until you design an active placebo which causes that same adverse event. So I thought I should give a brief example of that because it can be an important consideration with respect to certain drugs. In our case, that's not really very relevant because sacubitril, valsartan, and enalapril have a very similar set of side effects. So things like hypertension, angioedema, and whatnot. And so you wouldn't be able to tell the two medications apart purely by their adverse events. Now, the next question asks us whether an appropriate analysis was used to estimate the effective assignment intervention. That's subdomain 2.6. Now, this does sound like a mouthful, and it relates back to the reason why we chose intention to treat in this box right here. And we're going to try and explain it through a simplified diagram. So this is a diagram I've made right here. Okay, so let's try and walk through it step by step. Now, let's say I designed the trial so that there would be 2,000 patients in total, 1,000 assigned to enalapril, and 1,000 assigned to sacubitril valsartan, right? And let's say that initially, because of the randomization process, which tends to balance out the baseline prognostic factors, 50% of the enalapril patients had mild heart failure and 50% had severe heart failure. Likewise in the sacubitril valsartan arm. Right, so it's a 50-50 split of mild to severe in both arms, which is good because you'd want your baseline characteristics to be well balanced between two arms. Now, let's say that the trial eventually takes place and that the patients in the sacubitril valsartan arm, in particular the ones with severe heart failure, they start to experience severe hypertension, right? Because sacubitril valsartan more often causes hypertension than enalapril. Well, what's going to happen is that these 300 patients who experience hypertension in the sacubitril valsartan arm, they might cross over to the enalapril arm. So that now you have 1,300 patients in the enalapril arm. So these are the number of patients actually taking enalapril, right? And you'd only have 700 patients in the sacubitril valsartan arm. Now, the number of patients per se is not the problem. The problem is what did the patients crossing over look like, right? So the patients who crossed over from the sacubitril valsartan arm to the enalapril arm, these were patients who had severe heart failure. And so when they crossed over to the enalapril arm now has 800 patients with severe heart failure. The 500 that initially started out on enalapril, and the 300 with severe heart failure who crossed over from the sacubitril valsartan. Right, so it now has a lot more patients with severe heart failure, and instead of having 50% prevalence of severe heart failure, it now has about 62% prevalence of severe heart failure. Right, and when you go over to the other arm, the sacubitril valsartan arm, now it has a lot less patients with severe heart failure, right? Because 300 had crossed over to the other arm, and so now it would have approximately 29%. 200 out of 700. Patients with severe heart failure. So if you were to analyze the patients by the medications which they ended up taking, the baseline characteristics would be severely imbalanced. You'd be analyzing enalapril with almost twice as many patients with severe heart failure, right? With twice the proportion of patients with severe heart failure, I should say. 29% versus 62%. And so this is why we usually don't end up analyzing the trial by the number of patients taking a specific intervention. Because if we do that, we might induce imbalances in the characteristics between the two arms. And so what we usually prefer doing is assessing patients based on the arms to which they were assigned, right? So you will take those 1,000 patients who were assigned to enalapril and analyze them in that arm, and 1,000 patients who were assigned to sacubitril valsartan and analyze them in that arm, without taking into account the fact that 300 patients with severe heart failure crossed over from the sacubitril valsartan arm. Because if you do that, if you analyze enalapril as though 1,300 patients were in that arm, and sacubitril valsartan as though 700 patients were in that arm, you'd be completely messing up the baseline balance that you achieved via using randomization. And you'd be comparing two groups with very different sets of patients, right? Now, the first way to analyze this, as we'd mentioned, is analyzing patients according to the arm to which they were assigned, and that's known as intention to treat. So in intention to treat, you analyze patients according to the groups to which they were assigned, right? So 1,000 in this arm and 1,000 in the other arm, right? That's called intention to treat, and that's what we want. That's what maintains randomization. That's what preserves the balance of the baseline characteristics. Now, the other approach where you analyze patients according to the treatments which they ended up taking, that's called an as-treated approach or a per-protocol approach. And that's the approach which can cause severe imbalance in important prognostic factors. And therefore, what we would like to see in most trials, and what we analyze trials according to, is the intention to treat principle. Now, let's go over to our trial, the PARADIGM-HIF trial, and take a look at how they analyzed patients. So we see in this flowchart that 4,187 patients were assigned to sacubitril valsartan, that's LCZ, and 4,212 patients were assigned to enalapril, right? And usually you'll find them in the statistical methodology section right here. Just a sec, yeah. Yeah, here. You'll usually find them elaborating on which type of analysis they used. So they say we included data from all patients who had undergone a valid randomization in the analysis of the primary and secondary outcome according to the intention to treat principle. And when you go to table 2, you'll find that indeed the number of patients in each arm is exactly that according to that arm at which they were randomized. So that's reassuring. That tells us that they did analyze patients according to the arm to which they were assigned, right? And that's a good thing. Now, let's assume that we had a trial whereby a number of patients crossed over and they did not use intention to treat. They analyzed them according to the per protocol approach, right? How would we judge a scenario like that? Well, the way we judge a scenario like that is according to the number of patients who crossed over. So in our previous example right here, 300 patients had crossed over, right? And that caused a really severe imbalance in the baseline characteristics. Now, if, let's say only 5 patients had crossed over, then that would be much less troubling, right? So there are two important domains or subdomains rather to consider here. Did they use an intention to treat analysis? And if they did not use an intention to treat analysis, was there enough crossover to the point where it would be problematic? So in this analysis, they used an intention to treat principle, so the second question is not really relevant. So if I go over to the Excel sheet here, I'll type in no, or yes rather, actually, and it will white out the next question. Now, if I typed in no, that they did not use an appropriate analysis, Then I'd have to take into consideration how many patients crossed over, and I'd essentially have to answer this question. Was there potential for a substantial impact because of the failure to analyze patients according to the group to which they were randomized? And you'd have to judge that based on, how many patients crossed over. Was it a relatively large proportion, and could it have induced an imbalance in their prognostic factors? In this case, it's not really very relevant, so I'm going to type in yes here. I'm going to type on, click on the algorithm button, and I'm going to choose a low risk of bias, right? So, that's the second domain, the deviations from intended interventions domain, and that's the domain that's most time consuming most of the time. Now the next domain, which is thankfully much easier and more straightforward to answer, is the missing outcome data domain. Now the first question in this domain is, was there outcome data available for all or nearly all participants randomized in the trial? Now to answer this question, we're gonna go over to the trial PDF, and we're gonna take a look at figure 1, which generally shows the patient flow across the trial. And we're gonna see that about 11 patients had an unknown final vital status in the sacubitril valsartan arm, and about 9 patients in the enalapril arm. Now, our outcome of interest is all-cause mortality, and so these are the patients whom we really don't know their death/alive status. Those are the patients with missing outcome data. Now, to know whether this number is, large or small, we're going to go over to the number of patients who actually died, and that's generally provided in table 2. So death from any cause. Okay. So we see that 711 patients died in the sacubitril valsartan arm versus 835 patients, and this result was pretty strongly significant. Now, we know from in a scenario like this that these 20 patients, they would not have been enough to overturn the results. This is a scenario where even though you lost 20 patients to follow up, it's pretty clear that those 20 patients would not have been enough to overturn the results of something like this, where it's pretty clear sacubitril valsartan had a big advantage. And if you go over to the Excel sheet and type in yes, there was enough data for most participants, it's gonna block the rest of the questions, because the rest of the questions are only relevant if there was sufficient data to the point where it may possibly overturn the result, right? So if I typed in no, if there was indeed a fair bit of lost data, I'd have to answer the next question, which is there evidence that the result was not biased by missing outcome data? And this is usually something that's done by the statistician, whereby they would, assume what happened to the missing patients under a range of plausible assumptions, and show you that the results would not have been very different under these assumptions. In this scenario, we'll suppose that they did not conduct such an analysis. If they did, it would block off the rest of the questions. If they didn't, we'd have to answer the rest of the questions. And the next question we'd have to answer is, could the missingness in outcome depend on its true value? And this is where it's a case where you'd have to exercise your judgment, right? If the missingness on the outcome was, for example, because let's say you're measuring blood pressure and their blood pressure devices malfunctioned, in that case it would be fairly reasonable to assume that the missingness in outcome did not depend on the true value. It's just a case of a missing device or a malfunctioning device, right? On the other hand, if the investigators did not provide reasons that were pretty reasonable and clearly unrelated to the outcome, also, for instance, if they simply said that the patients were lost to follow-up and could not be contacted, well, that's a scenario where the patients could have died. It really could have something to do with their outcome. So in that case, you type in yes. it could depend on its true outcome. If you typed in no, that would be the end of it. But if you typed in yes, you'd have to answer the next question, which says, could the missing, or rather, is it likely that the missingness depended on the true value? Now, to answer this question, you're going to go over to the trial PDF. Now, in our PDF, there's a very small lost follow-up, and so this question is not very relevant. But if there was a lot of loss to follow-up, you're going to have to take a look at two things. Was the loss of follow-up balanced between the two arms in terms of numbers? So about, let's say, 5% in each arm. And were the reasons similar? So, a fairly similar mix of reasons for both arms. If it's like that, then you can be, reasonably certain that the outcome would not have been biased either way, because there was an equal number and equal reasons for loss follow-up in the two arms. If, on the other hand, you notice that one arm has a lot more missing data, that's much more worrying, because it could have been that the patients in that arm, died or developed some sort of severe adverse event, or something related to the outcome, right? Or rather, in another scenario, if the reasons for lost follow-up are very different. So, for instance, if the reason for lost follow-up in one arm is mostly, logistical stuff or the device malfunctioning or whatever, and the reasons in the other arm are not clarified or are said to be that the patients were lost follow-up and could not be contacted. That's another worrying scenario, because if there was no bias, you'd expect the reasons for lost follow-up to be equal in both arms. If the reasons are not equal or are not equivalent, then that's a very worrying sign that something might have gone wrong in the arm where the reasons were not clearly outlined. In our scenario, it's a very low risk of bias trial, because very few patients were lost follow-up. Right, it was only 20 patients, and we saw by looking at table 2 that those 20 patients would not have been enough to overturn the results at all, right? So we're going to pick a low risk of bias here. Now, the next domain we're going to concern ourselves with is the measurement of the outcome domain. Now, this one consists of several questions, as do previous domains, and the first one here was the method of measuring the outcome inappropriate. Now, this is not really applicable in our case, but it refers to cases where, for instance, if you're trying to detect, let's say, hypoglycemia, some glucose measuring devices are not very adequate in terms of detecting low glucose levels. So if you're conducting a trial like that to detect hypoglycemia, it would be completely inappropriate to use them. In our case, that's not really very applicable. Now, the next question asks us, could the method of measuring the outcome have differed between the two groups? Now, this refers to two main scenarios, right? If one medication involves more follow-up visits to the clinician or the hospital, so for instance, patients assigned to, let's say, if you're trying to compare warfarin with some other anticoagulant, patients assigned to warfarin will often follow up more frequently to monitor their INR, for instance. That could be a source of problems, because it could mean that warfarin patients get seen by their clinicians more frequently, and so they may detect more events in that arm. Not because warfarin actually causes more events, but because the patients are seeing the doctor more frequently. Another example would be if, for instance, a medication had or required rather some sort of imaging as a follow-up. Now you can imagine if you're comparing two medications to one another and you're imaging patients in one arm but not another, you will find more bad stuff in imaging in the one arm where imaging is part of the follow-up. So for instance, you might find more tumors, not because the medication actually causes tumors, but because you're only imaging the patients who are taking that medication and you're not imaging the patients in the other arm. Neither of these two is really applicable in our scenario, because all-cause mortality is something that happens only once. You're not gonna miss it if it happens. and it's not going to happen more than once in more than one follow-up visit. So that's going to be a no for this domain. Now the next domain asks us whether the assessor that the outcome were aware of the interventions received. In our case, that's a no, and so the rest of the questions get wiped out, and it's a low risk of bias assessment. However, if the answer was that the outcome assessors were aware, that is to say that you typed in a yes here, the next question asks you whether the assessment of the outcome could have been influenced by knowledge of the intervention received. Now, this would depend on the outcome that you're trying to assess. In our case, even if the trial were unblinded, it would be all-cause mortality, and so, there's no way something like that would be influenced by knowledge of the intervention received, right? Because either they're dead or they're not. Likewise with biomarkers, for instance, if you're measuring ANP, that's an objective biomarker that would not depend on any sort of subjective assessment by the investigators. Now, on the other hand, if the investigators are measuring a more subjective outcome, let's say they're measuring a patient's pain score or quality of life, or if it's a patient-reported outcome, so the patient is reporting their own quality of life, and they're not blinded, that could induce some degree of bias. And in that case, you would answer that this question, could assessment of the outcome have been influenced by the intervention received? You'd answer that with a resounding yes, it could have. And you'd move on to the next question, which asks you whether it's likely that it did indeed influence the outcome assessment. Now, you're going to have to exercise some judgment here. In cases where you're comparing, let's say, an active drug to a placebo, in those cases, it's much more likely that the outcome will indeed have been influenced by the intervention received, that the assessment will have been influenced by the intervention received, because the patients, they might experience, or they might rather believe that the active drug is really beneficial, and so they might report improved quality of life, even though the drug really doesn't have an objective effect on the quality of life. Or if it's something that's assessed by the physician, so if the physician has to assess the patient's clinical status, if the physician really believes that the drug works, so if they're invested in the drug, if it's an active drug that's that they believe to be working, they're likely going to rate people who took the drug as having better clinical status than those who didn't. And so in that case, it might well be that the outcome could have been influenced by the intervention received. In fact, it's not just that it could have been influenced, but it is likely that it would have been influenced, because there is a strong belief in whoever is assessing the outcome that this intervention really does have an effect. Now, considering the fact that the outcome adjudicators in our study were blinded, and that our outcome was pretty objective, which is all-cause mortality, none of these domains are really relevant. And you're going to pick no here, and it's going to wipe out the rest of the domains, and there's going to be a low risk of bias judgment. Now, the next and thankfully briefest domain is the selection of the reported result domain. Now, this domain is mainly concerned with trials where the investigators carry out the trial, they get their data, they perform the analysis on their pre-specified outcome, and they find a non-statistically significant result. That is, they find a p-value greater than 0.05. And what they do then is they chop up the data in 100 different ways up until they get a statistically significant result. Now, this is not a very proper way, as is obvious, of analyzing the data, because if you chop up the data in 100 different ways, you're going to come across something which is statistically significant. And so this domain is concerned with trying to fish out cases where this happened, where this kind of post hoc fishing happened. And so the easiest way is to tell if this could have been a possibility is to see if there is a protocol which pre-specifies the outcomes of interest, as well as how they're going to be measured and assessed. So the first question in this subdomain asks us, was the data that produced this result, in our case this all-cause mortality, analyzed in accordance with a pre-specified analysis plan finalized before the unblinded outcome data were available for analysis. Now, to check this, we're going to have to go over to the protocol, which is freely available, and we're going to see under the statistical analysis section that they do have a pre-specified analysis of all-cause mortality. And they specify how it's going to be analyzed, and we see that they have already said that they'd use a proportional hazards model, that is a model which will produce a hazard ratio, and that they would present their Kaplan markers, and that they would report the frequency and percentages. And they do all of that stuff in the primary study PDF. And so, that gives us reassurance that this was not something that was, fished post hoc. It was something that was pre-specified as part of the analysis. The next section concerns things like multiple eligible outcome measurements, and these include things like, for example, if you're trying to run a trial on depression, and you have, let's say, 3-4 different depression scales by which you could measure the outcome. If you measure the depression in patients using 3 to 4 scales, and you only report the scale that got you the statistically significant result, that's going to be very vulnerable to bias. And so it's very important, if it's a subjective outcome which could be measured by a more than one scale, that you pre-specify which scale you're going to use. It could also be a matter of changing the definition post hoc. So if the trial specifies major adverse events as an outcome without pre-specifying what exactly major adverse events means or refers to, that's a problem, because they could simply, change the definition up until they get a statistically significant result. And time points. So if a trial, measures an outcome at, 10, 20, 30 weeks, and it only reports one of these measurements, it's going to be a problem, because they're likely going to only pick the one that's statistically significant. And none of these are concerned with our trial, because they reported the all-cause mortality at the end of the trial, and there are no scales or different definitions for all-cause mortality. It's a pretty clear-cut definition. And the final point, which is the multiple eligible analyses of the data, concerns scenarios where they could have used different models. So in our case, they pre-specified a Cox proportional hazards model, and that's the model that they actually ended up using in the paper. But you can imagine if they said that they'd use a certain model, and then you found a completely different one in the final paper, that should be a red flag. Unless, of course, they reasonably explain why they made their changes. If the changes were reasonable based on some form of justification which you as the assessor perceive to be okay, then it wouldn't be a problem. So in our case, it's a yes here and a no for both of these, and that will give it a low risk of bias. And this is basically the summary of the risk of bias 2 tool. The final step would be the overall bias. Now, this is determined by the previous judgments of bias you've passed on these 5 domains. And since in our example all of them were examples of low risks of bias, we're going to pick a low overall risk of bias. And that's going to be it. Now, in order to actually see your results, you can click on the Results tab here. And each column is going to represent a certain domain, right? So in this case, the first set of columns will represent the randomization process with our judgments. The second will represent the deviations from intended interventions, with the final algorithmic result as well as the assessor's judgment. And there is another tab here, which is the summary tab, and to view the results here, you're just going to have to click summary here, and it's going to generate a record here with the basically a summary of your judgments. So we can see that all of them are low as we passed them originally, and that the overall risk of bias is low. And to generate a new record, you just have to click here and then type in a new assessment ID, and that will be that. Thank you for listening.